Hello, it's Doug Holland, a licensed massage therapist, with a tip for massage therapists that are addressing patients with low back pain that simply does not get better with each massage. And we've all probably experienced it. I know I have. You constantly work on their low back, let's say the quadratus laborum or the erector spinae group, the low erector spinae group. And the person will say, the patient will say, well, I felt good for a day, maybe 2 days. And then the pain just came right back. So you do the massage again. A week later, yeah, the pain came back. Do the massage again, over and over and over. You keep repeating yourself because you're addressing where the symptom is, but it might not necessarily be the cause itself. So they give you some ideas of what actually might be taking place. They sit all day. Maybe subjectively they tell you they sit for long periods of time. Maybe they're a professional bike rider, and so they're doing a long rides, maybe up to 50, 75 miles at a time. And so you take mental note of that. But objectively, what you notice is when you have them standing and you have them on the frontal plane, you'll notice if you look at the top of their pelvis, it's actually tipped forward and the butt is back. I have a hard time doing that. Okay, I'll stick my chest up and try to do that. So the pelvis is tilted forward and the butt is back. We call that duck butt. But what you see is a abnormal curvature of the low back, which is hyperlordosis. Okay, so they have this abnormal curvature there, which tells us that the front of the pelvis is being pulled forward and down. Okay, that's anterior pelvic tilt. Now, imagine the low back muscles are trying to pull it back up straight. They're trying to cause extension to the spine, and then the flexion is pulling forward. So what we want to look at is the hip flexor, the primary hip flexor, which is the psoas major, the problem, and most likely it is. Now we won't talk about the iliacus, which we know is also in that same area, or the psoas minor, but if we focus on the major, there's a way for us to go ahead and get that so that we can relax that muscle group. Now, you want to be careful. You probably don't want to do this on a brand new person. They might not come back to your office. But if you have an individual who's either had sports massage before or had deep tissue therapy before, and they recognize that you're going to make this technique on them and you have their best interests at heart, they might let you do it because it is probing. So what we're going to demonstrate here is how to first find it from the anterior side. So what I'm going to do is I'm going to locate on the pelvis where the anterior superior iliac spine is. Now we know we got two muscles that come off that. That's the sartorius and the tensor fasciatum. Those are the two that originate off there. So we're going to be just above that muscle group. We're going to find the crest, the iliac crest, where it rounds that corner there. And then we're going to locate the belly button. So what I'm going to do here is I'm going to find her belly button. All right, and then what I'm going to do is I'm going to split the difference between the two of them. I'm going to just take my thumb and I'm going to find, okay, there's the difference, right in the middle there. Now, when we're going to press in to find this psoas major, we're going to actually be moving a little bit of the intestinal tract. On this side, we're going to be moving the ascending colon a little bit out of the way. When we're on the left side of the body, we're going to be dealing with the sigmoid flexor. So we want to be careful as we go down in there. We want to gently be moving the soft tissue out of the way. And if you feel any kind of, the teacher that taught me said you feel a pulse, and get off of it, okay? So what we're going to do is we're going to have Lori raise her right leg first before I start to press inward. And I'm going to take my hand and I'm going to slide it on a slight angle down towards the psoas major. Now I'm not going to go real deep on her because she's sensitive, but we're going to go down until I make contact with this muscle. All right, I think I'm on it right there. Now, how do I know when I'm on it? Is when she starts moving her leg. So what I'm going to have her do is I'm going to have her dorsiflex her toes, which means raise them up, keep her heel tight on the table, and have her slide her heel down nice and slow. See, I can feel the muscle moving underneath my fingers. Nice and slow. Nice. Oh yeah, I feel it. Okay, once her leg is flat, I'm going to have her externally rotate her foot really slowly. then we're going to go ahead and internally rotate it. Okay, very good. And then let's go back to neutral. Now why do we do that? That movement there, it causes cross fiber friction. I'm actually doing cross fiber friction. As she's the one that's actually making it happen, I'm just holding onto it like a guitar string. All right, and then we're going to have a re-dorsiflex the toes. Re-dorsiflex the toes. That's plantar flexion. Dorsiflex, there we go. And then we're going to raise the heel back up. Nice and slow. And that would conclude the exercise. Then we take our hands off really, really slowly. It'll be really uncomfortable if you've never done this technique before because you're going to feel all that soft tissue going all the way down. And then when you feel the muscle, it's going to be pretty taut. It's going to be hypertonic for sure if they have anterior pelvic tilt. And then once you feel that banding going back and forth as you press down and the muscle is being rotated back and forth like that, you're going to actually feel those fibers bouncing on the tips of your fingers. It's important to do that exercise maybe 2 or 3 times, give them a break in between. You want to work both sides. We always work both sides, whether it's right side or left side, doesn't matter. We're always going to work both sides. But again, work with their pain tolerance. You go in there, a lot of people describe nausea. They almost feel like they want to throw up when you're pressing down into that abdomen. That's okay. You just got to work through it. Now, after you do a treatment like this on the patient, really have them take note of how many days that they actually have relief. And if they have relief that comes off the back itself, you'd be very, very surprised on how that does. Now I'm going to have her flip over. If you would flip over on your front side there, please. When she lays down prone, now I'm just going to demonstrate with using the opposite leg here. There's another way to get a stretch into the psoas major. What we're going to do is we're going to grab the leg here, and I'm going to scoop my hand up underneath the knee. And as you notice, I have good support by holding right up underneath there. I have my arm is parallel to her leg there. And what I'm going to do is I'm going to find the posterior superior iliac spine of the ilium there. I'm going to find that, and I'll take the heel of my hand right there on that thenar eminence. I'm going to press the thenar eminence right up against that posterior aspect. I'm going to lift the leg while pinning the hip, and then I'm going to abduct the hip. Okay? So you're also going to get the pectineus in this, a nice stretch in the pectineus, but what I'm doing is I'm forcing the flexor muscle to stretch. And this is hard for people to do on their own because usually they're doing Samson stretch or something like that, and there's always other muscles under tension. But here, we're not going to have other muscles under tension. So I'm going to lift and I'm going to hold. It takes a little bit of strength to hold the person's leg up like this, and I want to do a full minute, and then I'm going to bring the leg back to neutral, set it down, and gently put the foot down, try not to crush the toes. Okay? Now, I got a picture here. I'm lazy. I'm not going to shoot a separate picture, so I'm just going to go ahead and bring it up. You can see the psoas major right here. This is the primary one that we're going for, and you can see between here and the transverse spinous processes of the lower lumbars, that's the part I want to hit when I'm working that muscle, okay? And you can see here how it hooks underneath the femur. That allows for external rotation of the hip. If it was on the anterior side of the femur, we'd only have flexion. But since it goes behind the femur, we're going to get external rotation along with the hip flexion itself. So that's my tip for you guys. If you have any questions, I'll do my best to answer them from the video itself. And just if you like this video, hit subscribe. We're going to be making hundreds of these videos. We got all of our new equipment to do this now. Just remember, you know, it ain't dead tissue therapy if there's no pain. It's you're going to have some pain in these therapies. Otherwise, it's just a foo-foo massage.